So I'm going to talk about, so I like to say I'm a time use epidemiologist, so how we measure physical activity, sedentary behavior, and sleep. I thought I'd go through a little bit of my background because as a student, I was always interested in, hearing how people got where they were and how they came up with their research interests. So yes, I'm from Texas. We had a great weekend rivalry game, and now we're on to the SEC championship. So I was on the rowing team. So again, so just try and find groups of people that you really mesh with. So I was a softball player. And then when I went to school, I decided to join the rowing team. I also took a lot of different varied interests in psychology. And so one of those classes was health psychology. So why are people choosing different behaviors that, really impact their health? I also volunteered on research studies. And one of those was as a research assistant, looking at how kids are being physically active with like we, and how that relates to cognitive function and their education. So while I could have, left right after, I was really interested in, this brain function, how physical activity really impacts health. So I decided to keep going. And I got a master's where, dating myself a little bit, but this is when the Apple Watch first came out. And the Fitbit had just come out and started doing heart rate. And so no one really knew if those were even valid. So that was my master's thesis. So I put a bunch of undergraduate students in my classes on a treadmill, hooked them up to a gas machine, and then put a bunch of different devices on the students and had them complete, first they were sitting, then they were standing, then they started lightly walking all the way up to jogging. And all that time I was measuring how accurate these devices were for capturing their heart rate on the wrist. You can see which one I chose then to wear. So the Apple Watch to me was the most valid in that study. So that was my first thesis, and kind of, I started this project from start to finish and really got my interest in wearables. So I decided to keep going and get a PhD where I was a part of a lot of different projects. While at the UT Health School of Public Health, there was a lot of focus on children. And so some of these projects were looking at environments that children are in. So I did a lot of work with like preschoolers. They wore a device and we saw how they interacted with their environment. So then I went on to continue working with devices at the National Cancer Institute, and I will highly recommend all students look at the NIH for any type of post-career things. So there are post-bachelor training awards, there's post-masters training awards, and then I did the postdoc, but again, there's postmasters as well. So if you're not sure if you're applying for jobs in the next few months, I would highly recommend looking all around NIH and go live in DC. It's very fun. And then I came here and I've been here for a few years now, and third year starting as the assistant professor. So while it seems pretty straightforward, definitely when you're in the thick of things, it's a jumbled, confusing mess, where's up, where's down. Just keep following your research interests and you'll find a path that you love. Okay, so why physical activity? So I was always active, but really if we think my research interests are now across the life course. So I've done some work in the early children, now we're in young adults, midlife, and older adults. Physical activity impacts and is related to all of these different life stages. And we can also think about how it's related in all these different levels of prevention. So physical activity can help with primordial prevention. So if you think about at the population level, impacting people's physical activity when they're not even really noticing it. So they have access to blue and green spaces, they're more likely to be physically active. Physical activity can also be at the primary prevention level. So how do we prevent CVD in the future? We can think about physical activity reducing adiposity and blood pressure. secondary prevention or screening. We can think about exercise testing and ways that we can catch early disease. And then tertiary prevention, physical activity is still important when you have a disease and you need to manage that disease. And you don't want to get more disease, or if you want to reduce some of your disability. So just to go through a little bit of the physical activity guidelines, just in case you're not aware, for children and adults, the physical activity guidelines suggest for best health benefits, children should do 60 minutes or an hour every single day. So those are the best health benefits for kids. And then for us as adults, it's 150 minutes over the course of the week. So you don't have to get all of your physical activity every single day, but you should spread it out throughout the week and try to get about 30 minutes 5 times. So 150 minutes. And then you should also be trying to do some muscle incorporating activities at least 2 days in that week. So sedentary behavior and sitting does have independent relations with all-cause mortality and health, but it also has kind of this joint independent effect with physical activity. So we see that people who are getting those physical activity guidelines, so about 30 minutes a day, no matter how much you're sitting, if you're getting physical activity, you're reducing your risk of all-cause mortality, according to this. However, if you have less physical activity, so this is the second tertile of activity, they're getting about 11 minutes a day. Your risk of death does start increasing the longer you are sitting. And if you're getting the least amount of physical activity, so these participants were only getting about 2 minutes per day, that sedentary behavior was not attenuated at all by physical activity. So trying to get the physical activity guidelines. But with sedentary behavior, we're not really sure how much is too much. And so the guidelines just say to you, sit less, move more, try to limit your sitting. And then if you're ever working with, in a public health practice or any type of campaign that they're looking at physical activity and sedentary behavior, there's all these toolkits a part of the NIH that you can use to help you with your campaign. Now, light intensity physical activity are things that we do every day. So walking, housework, yoga. So not your jogging, your cycling, it's more of everyday activities. And that is also really beneficial for your health. So you can see here on this graph that as your light intensity, physical activity increases, your risk of death will also decrease. And there are some trackers out there that are already starting to think about how we can incorporate housework and light intensity into your everyday activity. However, there's no current guidelines for how much of this daily movement we should be getting. And then lastly, I want to talk about sleep. So sleep's really important for health. And the guidelines as adults are 7 to 9 hours. So time use epidemiology was kind of built on this thought of we've been in these silos of sleep researchers, physical activity researchers, sedentary behavior researchers. Really, when we think about 24 hours, like your daily activity, everything's all related. You can't change one behavior. You can't ask someone to get more physical activity without them either having to reduce the amount of time they're sleeping. So they need to get up earlier and be physically active, or they need to reduce the amount of time that they're sitting. So with time use epidemiology, really interested in determinants, effects of health-related patterns of someone's 24-hour day. How can we prevent unhealthy time use and ultimately try to achieve really good optimal time for physical activity and health? So if we really think about when we talk about physical activity guidelines, 30 minutes a day is really only 2 to 3% of all of your waking time. So looking at it holistically is beneficial. So this year I actually had the privilege of being on the committee that created the United States report card for children and youth. And so we were a group from all over, from all different universities in the US. And we assigned a grade for how well children and youth are meeting guidelines. And it's not great. So for physical activity, the grade is a D minus. So only about 20 to 30% of children are getting those 60 minutes of physical activity a day. And it starts decreasing as children get older. Same with sedentary behavior. Only 20% of children are getting less than 2 hours of screen time per day. And then I was the lead for sleep. And we're doing a little bit better, but really only about 60% of children are getting the recommended amount of sleep. And it does decrease. There are disparities. So with lower socioeconomic households are less likely to be meeting their sleep guidelines. And adults really aren't doing that much better. So if we think about just the meeting the physical activity guidelines, only about half of adults are meeting physical activity guidelines. And if we think about meeting it with the muscle strengthening, it's only 1 in 4 US adults. Sleep is also pretty poor. Only 2/3 of the US adults are reporting meeting 7 to 9 hours of sleep. And if we think about short sleep duration, which is less than 7 hours, we're actually, the trend is that we're getting less and less sleep as US adults. So. Okay, so now kind of transitioning to why it's important for 24-hour use to how do we measure these behaviors. So there's a lot of different ways you can measure it reported or with a wearable. I always have to slow myself down and say wearable because I've been told I sound like I study werewolves. I was like wearables, not werewolves. So you can think about questionnaires. So 2 weeks ago when Dr. Judd came by, she said they were really duking it out for regards on, they want to ask so many different questions to their participants that the researchers really needed to kind of put up their fists to fight for their, what they're interested in. So with physical activity, there's a lot of different ways you can measure it. You can think about questionnaires. So think about maybe 2 questions you can ask someone, or even 1 question. How many days of the week are you getting 60 minutes? So 1 question, very low burden, doesn't cost a lot of money. You can also think of hierarchy of questionnaires. So you can have participants fill out diaries. This becomes a little bit higher burden on your participant. But you can get a little bit more information, like what types of physical activity are they doing? Are they doing more housework? Are they doing yoga? We can directly observe participants. So I can go and sit at a park and directly observe what participants are doing. I can also put a GoPro on a participant and follow them around, and then have to review those hours of video and record what the participant's doing. So that's really high burden, both on me and the participant, and it also is very high cost. And you can think about how a participant may react to knowing that they have this video camera attached to them. Where I kind of like to land is a wearable. So there's the accelerometers and pedometers. So your pedometers are going to be your step counters, very low cost, low burden. And then we use a lot of times this accelerometer device. They're very expensive, but they are pretty low burden on the participant. They can just attach it to their waist, wear it for 7 days, but they, are knowing that they're being tracked. So I think when you're creating your research study, you need to think about your participant that you're going to work with, your budgetary restrictions, how many participants do you need to measure, and this is kind of how you work through what you want to use as a time use epidemiologist. Now, there's many different types of devices. We put them in kind of two basic buckets, a research grade and a consumer based. So your research grades are ones that typically don't have any type of participant interaction. So this one doesn't have their steps, they can't see it, they don't know how physically active they're being. They can wear it on their thigh, on their chest, on their wrist, on their hip, but the participant's not really doing anything with it. On the other hand, we have lots of different types of consumer devices. You have ones that you wear on your finger, on your wrist, the Whoop, the Fitbit, Apple Watch, and they all have pros and cons. So we typically use research grade in an epidemiology study because as a researcher, we have a lot more flexibility in how we can but how we can interact with the data. Whereas the consumer-based, which I learned when I was doing my thesis, you're constantly dealing with software updates. And it's like this black box of what the company's doing. Like, I don't know what the software update is, that going to change the way they're detecting steps. If you do use it with a research study, so there are lots of studies that use like a Fitbit device. Participants are asked to sync their device to some cloud-based system. So you're constantly having to tell participants, hey, remember to sync. Otherwise, the data actually rewrite over each other. So if a participant doesn't sync to your software and your study, that data is gone. And then also with these devices, you typically need a smartphone. So you have to think about, does your participant have access to that? Everyone needs to do a stand up. No, okay. Huh? Or are you going to need to provide your study participants with a smartphone so that they can participate in your research studies? So again, lots of pros and cons. Cons of accelerometers are they're very expensive, right? They can be anywhere from $300 to over, thousands of dollars. So you have to keep that in mind when you're working with participants. Well, we like to use these because we can actually have participants wear two at the same time. So for physical activity, we like to use kind of this trunk area because it's a little bit more stable when someone's moving. And for sleep, we like to use the wrist. It's a little bit more accurate than the trunk for detecting someone's sleep-wake patterns. I've also been on a study where we connected a GPS to participants so we could really see how the participant is moving through their space. Are they using sidewalks? Are they in a car? And you can do that with those types of devices. Now, maybe you're working on a study and you're really interested in how someone is utilizing your new bike path, or are you, they're biking to work? Are you working with a sit-stand company and they really want to know if people are using their standing desk? There are devices for more sedentary time behaviors. You wear it on your thigh via a sticky. So that does have some participant reaction because they have to stick it on their thigh. And if you can think about pulling off sticky on it, a hairy leg, not so fun. Okay, so as a researcher, this is kind of the data that we get back from a participant. So we get back a kind of log of the participant's day, and there's all these spikes and peaks. So we can see that this person put on their device around 7, And then they had this really high activity peak. And then they were being kind of active throughout the day. There's another little peak of activity, and then they took off their device. So as a researcher, we use these data and we assign different thresholds for what that physical movement probably is. So anything below this red line that, again, we're coding this in SAS and R and in software. So anything below this line, we would think of as this person's being really sedentary, they're sitting, they're lying down. Anything below this green line, they're likely doing everyday activities. They're doing yoga, they're walking around, they're doing some housework. And then anything below this blue and pink line, and in between the green is the physical activity. So running, biking, those types of things. And so we count all this up, and each minute we say, oh, okay, this person has about 1 hour of moderate to vigorous physical activity per day. So they're likely running. And then here they're likely taking their dog for a walk after dinner. So this is also included in that physical activity. So they're getting about 1.5 hours per day of that activity. And the same type of thing happens with sleep. So we get back all these little peaks and valleys of someone's daily activity from their wrist. And we use this algorithm, and we use software to kind of hone in on where it starts looking flat. And that's how we measure sleep. So it's a little bit kind of cut off here, but it starts around 11 p.m. for this person, and then goes till the next day when they're waking up around 7:30, 7:45. But ultimately, why I love working with wearables is because, for example, in the All of Us study, they asked participants to sync their own wearable device. So if they had a Fitbit, they could sync it to the software cloud, and researchers can really look at this. And some of these participants have been wearing a wearable device for anywhere between 3 and 7 years. So we have daily physical activity for someone about 7 years, and we can see and graph how this relates to, for example, diabetes and hypertension. So the more, for example, steps here that you're getting, the less likely you have diabetes, or the less likely you have hypertension. But with all of these devices, there are different validity and accuracy. And so you just need to be careful when you're selecting a device for your study. Particularly if you're working with older adults or those that may have a disability or comorbidity, because some of these devices like the Fitbit, as participants self-walking gets slower and slower, the accuracy is going farther and farther down. And then same with things on your wrist or your finger. Are we capturing someone lifting weights, or are we capturing someone eating food? Also, sometimes, when this thing tells me to stand, I just wave my arm around if I don't really want to stand up. So there are pros and cons. And when you're selecting a device for your study, you need to balance practicality of your participants in your study with accuracy and precision. Okay, so now moving a little bit to some of my work. So again, at the National Cancer Institute, I got to work with the NHANES data. So it's publicly available. There was a device worn on their wrist for 7 days, and they were anywhere from 3 all the way up to 80 wearing the device. And so what we were really interested in is kind of looking at how patterns across ages with physical activity look. And so you can really see it's very variable in the early ages. So these are preschool to school age children. And really physical activity is kind of peaking at age 7. So the highest activity levels are in the 6 to 9-year-olds. And then physical activity is slowly decreasing throughout the lifespan, early and school age. And then we had to split it. So ultimately, we really wanted to have just one big figure across the life course, but the model was just being all wonky. It really didn't like it. And so we really had to split between the right when you leave high school into coming into college. It's very variable right here. And then you can kind of see once you're out in college, your physical activity kind of plateaus, and then it starts decreasing as you age. So again, it's very variable in this early young adult life age. And so this is a graph for males, but we also very similarly saw this pattern with females. So you're peaking in early education, and then you're very variable, and then you start plateauing in young adulthood and midlife. And the same can be seen with sleep. So sleep is also very dynamic, just like physical activity. You're getting the most amount of sleep when you're younger, and it starts plateauing really when you're 18 to into your emerging adult and young adulthood. So for those students out there, yes, early and emerging adult is very dynamic for physical activity and sleep. So emerging and early adult is anywhere between 18 and 44. It's really a time when you're moving out of the house, you're getting your education, your first jobs, meeting your life partner. So your physical activity is all impacted by all of these life events that you're experiencing right now. And so with physical activity, I think you need to just really be mindful of trying to get your physical activity guidelines. So the CARDIA study, in which Birmingham is both the coordinating center and a field center, this recruited participants when they were in this emerging young adult, very dynamic period back in 1985. So when they were 18 to 30. And we've since gone on and studied them about every 5 years they just ended the 35th year, and they're scheduled to start the 40th year around 2025, 2026. And so we have devices on participants at year 20. So right when they were ending kind of this emerging young adulthood. And then years 30 and 35, and then hopefully year 40. So I want to present one little study that I did where we looked at the data at year 20 and looked at all-cause mortality 15 years later. So that they are premature deaths, right? They're deaths before age 65. Okay, so we have different panels. So right here I have sedentary activity. In the top right is light intensity. In the bottom is the moderate to vigorous, so more of your exercise minutes. And then in the bottom right is just total activity counts. So all of those physical activity and light intensity all combined. And then I looked at this separately for both men and women because just like we saw, while the patterns are slightly different, or the patterns are kind of the same, where men and women are slightly different in the amount of physical activity they're getting. So I did not see any, results for premature mortality for sedentary behavior. However, for light intensity, you can see that as participants get more and more light intensity minutes, their risk of death, premature death, decreases. This was only statistically significant for women who are in the yellow bar compared to men who are in blue. Similar patterns, just that the confidence interval does cross 1 for men. Surprisingly, the moderate to vigorous physical activity was not statistically significant, but you kind of see the same similar pattern. A lot of times with physical activity research, we do see this J shape where the most amount of risk is in the lower end, but then also in the upper end. So there is some risk with physical activity like heart attack at some high ends. But when you combine the light and the moderate together with total accounts, there is the statistically significant results for women. So light intensity physical activity and total physical activity is very important, particularly for women in this age range. I didn't see consistency with men, but I do have some thoughts that a lot of men had higher risk of death in CARDIA, but they were dying of unrelated things to physical activity, such as like homicides and other related death. So women were the leading cause of death was more cancer and things that are related to physical activity. Also, there's been this push towards this occupational physical activity paradox where physical activity you're getting during your job may not actually be as beneficial as physical activity that you're getting outside of the workplace. Especially for, physical jobs that are very physically demanding, because you're sustaining this heavy load on your body and it's never able to fully recover. And so maybe that's why I didn't see as much results with the men. So again, going back a little bit to the NHANES data set, so I'm really interested in how physical activity is related to chronic disease development. And so if I look at, I started at early adult, so higher physical activity in the yellow is someone who has 0 or only 1 chronic condition. So they are getting higher physical activity compared to others of their similar age. And then as you start accumulating chronic diseases, your physical activity is impacted. So here we can see even in early adulthood, having 4, which is this dark green, or 5 chronic conditions in the black color, is really reducing people's physical activity. So I was interested in also kind of doing this with CARDIA data because NHANES is cross-sectional, but with CARDIA, we can really see if this is individual. So here we have multimorbidity starting at their exam back in 1985, and all of their chronic conditions that were accumulated over 35 years, and relating that to 2 time points of physical activity at year 30 and then year 35. So I was able to work with some the co-authors. So Barrett Bowling, he created this trajectories of trajectories of accumulating chronic conditions, so multimorbidity. So as you age, there are about 6 different trajectories that you may accumulate multimorbidity with. So there's this group that starts accumulating chronic conditions in their mid-20s and then just keeps accumulating more and more chronic conditions throughout life. So by year 30, when they're in their 50s, they're already having almost 4 chronic conditions. Comparatively, there's a group in the mid-20s that has a chronic condition, but they are more managing this chronic condition. And so they're not accumulating disease quite as fast as this top group. There's another group here that starts accumulating late in their young adulthood and also accumulates pretty quickly. So they're almost at 4 conditions, just like that first group. And then there's some other trajectories accumulating later and later in the life course. So I was really interested in taking Barrett's multimorbidity trajectories and relating these to physical activity. So really, I was thinking when I first thought about this study was that I thought if you had different trajectories, especially like those late 20s fast, that would really exacerbate your decline. So everyone naturally declines with their physical activity over the life course, as we saw. But I really thought if you had accumulating different trajectories of chronic disease, that might change your pattern. Well, not quite, but we can kind of see that sedentary behavior over 5 years was actually pretty stable across the CARDIA group. And it just matters kind of where you start. So this early 50s slow is kind of the healthiest trajectory pattern, and they have the least amount of sedentary behavior. Versus that mid-20s and late 20s fast groups, with their chronic conditions, they had the highest sedentary behavior. And actually, they're all pretty similar with their amount of kind of everyday light intensity physical activity. That late 20s fast had the fewest. And then for the moderate to vigorous physical activity, all groups decreased physical activity, and they all pretty much decreased at the same rate, if you will. It just really matters where you start. So the early 50s fast, early 50s slow, that healthy trajectory is starting much higher. So they have more cushion, I guess, to reduce their physical activity than those early 20s. And then here's another one with CARDIA. I'm calling it kind of CARDIA Plus because we were one of 15 other cohorts that was able to take this device, translate it to steps, and look at kind of what's the metric for steps. You may hear 10,000 steps a day everywhere, but really, as you start getting into older adulthood, it's more like 6,000 to 8,000 for those over the age of 60 to start reducing risk of death. And then for younger adults, so these were more like 45, 60, it's more like 8,000 to 10,000 steps. So you're not getting 10,000 steps, 8,000 is still pretty good. And then lastly, kind of just want to talk through a little bit more, whatever your research interests are with devices. Devices can be really cool ways to look at things. So we have physical activity fragmentation. So we can kind of look at people's aging. So kind of the secondary prevention, the screening. We can see if people are really starting to slow down, if they're not able to walk. Let's say 10 minutes, they have to take a breather and stop. That's called fragmentation. You can see that it increases with age. So that's something that could be kind of a marker, hopefully in the future for disease. Sensors can detect Parkinson's disease. So here this person's wearing different devices and sensors on their body to detect different movements. I like devices because, wow, there's also ones for animals. And so dog owners get more physical activity. So this was a study, unfortunately not by me, but I would love to do this, that has a tracker for the adult or the person and also their pet. So you can even look at your pet's physical activity throughout the day. And here's my pet. Dr. Gabriel, close your eyes. Modeling how to wear the device. So this is Odin. He's wearing it, showing you that you wear it on your hip. And then if you can't, get a dog, you can also, here I am. Back in Texas, there was this program called Rough Tail Runners, and you could go walk a dog at a shelter. So that is also something to maybe look into and pique your interests. If you're interested in animals versus people, maybe, I saw this really cool study where they put a activity tracker on a penguin in Spain, and they're able to tell temperature. These devices can tell temperature and light sources, and so they can track the animal in its natural habitat to look at sleep-wake patterns in animals as well. Anyway, I guess ultimately I hope that this sparked some area of interest in using a wearable device. Lots of adults in the US are a tracker. 1 in 5 Americans are currently using some type of device. I'm clearly a super tracker. I have a ring and a wrist, but just be aware that there are some disparities. So again, when you're thinking about creating a research study, really understanding your population of interest. And then lastly, for students, yes, we are implementing devices in lots and lots of studies. So yes, we have SWAN, which is study of women across the nation. Regards, the Jackson Hart study, we have a little study in Columbia and the Washington aging. CARDIA, Eric, my career development award, which I will be finishing in the next 2 years. So maybe I'll come back with some more interesting findings. And MESA. So ultimately, thanks. If I haven't seen you already in Epi 624, I hope to see you in January or starting in fall 2025. And then lastly, this is our research group, UAB scores, where we're looking at measuring physical activity and sleep and classifying outcomes. So if you ever have any interest in questions about which devices or whatnot, please contact us. We're happy to help.